Thank you very much for the opportunity to participate in this think tank on hearing in later life. My reality check is that I have had geriatric medicine as a career, but things have changed as I've got older myself, and them are us. In other words, they are me. I just put out some objectives here, and these are very general objectives that which I'm going to touch on in the presentation, and they're really in the communication realm. What are some needs to be considered on the front lines of healthcare for older adults? What is an ideal model of care for older adults, including changes that would benefit those who want to stay healthy and reduce their risk of future declines? And those who are beginning to have clinically significant cognitive declines, such as subjective cognitive impairment or mild cognitive impairment or even dementia. And finally, those who have more complex needs with comorbidities who receive home care or actually are in residential long-term care. What I like to think about with aging, as we all collect baggage as we get older, like to think about the bits. There can be a bit of hearing loss, a bit of vision loss, a bit of low mood, but not depression, a bit of grief, a bit of arthritis, a bit of slowing gait, a bit of altered balance. And no one of these things are really such a problem, but each one of them is contributing to how people manage on a day-to-day basis. So thinking about the bits and then focusing on function. How is the person managing? First of all, then identify the bits. Which of the bits can be changed even in a small amount? Which of the bits are the priority for change, especially given the person's goals or values? And what is the low-hanging fruit? What is the greatest bang for the buck? For example, in hearing situations, maybe cerumen management is the best thing to be pursuing. And a small success is a big step. If cerumen is removed and hearing is immediately improved, this is a big step. One has to take personal responsibility probably throughout life. The individual initiative is so important in terms of how well people manage on a day-to-day basis. There may be surrogate assistance plus responsibility, and certainly if you have a daughter in California, there could be a lot of pressure. Having a confidant available is also extremely helpful, because just somebody that knows you, that likes you, that is interested in your well-being, being able to speak with that person can make things that are impossible actually possible. Information access is something that we're all having too much of sometimes. And I think seniors really need to work hard to make sure that the information that they're getting, often through the internet, etc., is helpful information to them. And knowledge comes in increments. It doesn't come all at once. So what makes changes happen? Well, if we have early uptake, that can be helpful. And we also have to have belief and insight. Our lifetime education in terms of all sorts of things is helpful. Maintaining physical activity and certainly socialization, attention to nutrition, and attention to any health problems, assessment, monitoring, and treatment of comorbidity, everything from high blood pressure to pain to osteoporosis and many other issues. Now, in 2020, the 5th CCC-DTD, Canadian Consensus Conference on the Diagnosis and Treatment of Dementia, took place. One of the things that was looked at was non-cognitive markers of dementia. And one of the items suggested that there's enough observational evidence that hearing impairment is associated with the development of dementia. And a recommendation for assessing and recording hearing impairment in primary clinics, it has been undertaken at a fairly high level of recommendation. The real dilemma is, though, that particularly with increasing age, hearing impairment is very common and dementia becomes increasingly common. And the relationship between the two of them is continuing to be relatively difficult to figure out, even though they are certainly associated. Reducing risk is another issue that came up in the 2020 publication. And persons with cognitive complaints such as MCI or dementia and their care partner also, it's been recommended that persons are asked if they have any difficulty hearing in their everyday life. And that is supposedly a better way of asking individuals if they have hearing loss or not. And sometimes it is very true that people will talk about their difficulties rather than admit to actually having hearing loss. If symptoms of hearing loss are reported, then this can be confirmed by audiometry conducted by an audiologist. And in my personal practice, having available an audiologist was extremely difficult and time consuming. On the other hand, individuals were finding help with this kind of an issue on their own. And there are a lot of situations out in our communities where seeing an audiologist is a possibility. Now, I think that the very important part of audiology is the rehabilitation which may be recommended. And this rehabilitation is the behavioral counseling and techniques, and probably secondarily, looking at a hearing aid or device. Now, one of the things that I think is really critical in the 2020 recommendations is that more than the audiological examination is the importance of the otoscopic examination. In other words, it is so easy for a physician when they're seeing patients to look in the ears and have an intervention, particularly again if it's a cerumen accumulation. There are special times when it may be necessary to refer to otolaryngology, but that's a relatively rare situation in general practice. Now, overall, what is this about? It's about quality of life, and quality of life is based on having communication. When I asked my mother and my aunt, who lived together for a long time, what the most important thing for them was in terms of their own quality of life, they said, both of them independently, having someone to talk to. And certainly their socialization and activities in terms of long walks and so on contributed to their well-being over a lengthy period of time. They had a great attitude and were always looking for new opportunities. They fortunately had resources, including financial resources, and they valued living well and living comfortably. Now, we do live in a society where there's often recommended a pill for every ill or a device for every deficiency. And practically in every area, one needs to look at behavioral or social considerations to complement any of these kinds of needs. And even the pills are not as helpful as they can be if there's a complementary social consideration or behavioral consideration. And all of this requires attitude and initiative. Thinking that it's easier to opt out than to cope with the difficulty is not acceptable. So having the right outlook will be more helpful in our society. I'm a subject of the CLSA, the Canadian Longitudinal Study on Aging, and hearing screening revealed high tone loss, and I received the tracing along with the suggestion that I see my doctor about this. Of course, my son and daughter repeatedly suggested I have a hearing impairment. Eventually, I saw an audiologist and aids were recommended. Then COVID happened. After delay, I had the aids on trial for 2 months. I lived by myself. I only needed to turn down the radio while wearing the aids. There was no obvious benefit, but the aids dislodged when I combed my hair. They were also a problem when I put on my mask or took it off, when I went out shopping, etc. So, and furthermore, because of COVID, there are no opportunities to go to restaurants or plays where I had previously noted difficulties hearing. So my personal conclusion was the value was not at all offset by the cost and the nuisance. And I remain unaware of missing anything in the present environment. So I'm still taking advantage of potential neuroplasticity. And I think neuroplasticity, particularly as I've been reading about it recently in Daniel Levitin's book on successful aging, it's a concept of optimism. And can we work it? And I think we all should work it. In other words, there is data that more effective in older adults who rewire over many years, neuroplasticity is more likely. Many examples of adaptive neuroplasticity include on a day-to-day basis, everything from operating a new cell phone, using an iPad, using a hearing aid to enhance conversation, learning a new language, strategies to live with COVID, FaceTime, Zoom, and so on. There's so many great opportunities, and neuroplasticity leverages what our bodies can tell us about the world, how well our senses perceive it. There are more complex needs with comorbidities in individuals who receive home care or in residential long-term care. They have the same situation, but more obvious bits to prioritize and manage. Communication is really critical. And coming back to the hearing issue, a hearing aid could be in place, but is it on? Is it noticeable? Is it troubling? Is it irritating? Is it independently manageable? There are so many bits that one has to take into consideration with what could be a relatively straightforward intervention, or else it could be an intervention that is not useful at all. And certainly attention and concentration are big factors. So there are barriers and bits: hearing impairment, visual impairment, pain, depression, grief, changes in balance. And we need to build bridges for communication, bit by bit by bit, eye to eye, face to face contact. Lower your voice and speak slowly. Remove the background noise. Turn off the radio and the television. Speak with short statements. Don't ask, what veggie do you wish to have? Suggest possibly carrots or peas, or even say carrots or peas, and the person just has to answer yes or no. In summary then, I recommend focus on function, identify bits for action, initiate the action, follow up, repeat the follow-up, initiate additional action. This is in essence longitudinal problem solving with a goal to minimize risk and advance neuroplasticity. Thank you.